Whether you've been to all of our events or whether this is the first one, it is terrific to have you today. We have about 430 people on now. We usually get 800 people on these calls, and it tells you that there's a real need for information, and we're delighted to be able to present that today. So our goal is to be able to give you the best information on whatever the topic has to be, whether it's cancer, whether it's COVID, whether it's women's health or public health, whatever the topic is, we try our best to give the best source of information on these topics. And we look forward to spending the next hour with you and really having a great discussion about where we are. Today's topic is a year of the pandemic, progress on tackling COVID-19. I want to note that I started my role at the Fred Hutch on February 1st of last year. So a little bit over a year ago, I've been here at the Fred Hutch. And many of you may have gotten copies of our annual report, which talks about what's happened here at the Hutch and all the different areas that we've been able to look at, work on, and contribute to, not just in COVID, but across everything that happens here. So if you haven't seen that, please, we'll make sure we get a copy of it to you, and they can put the link in the chat area so you can see that. So what we want to do today is really talk about we're a year into this. And what does this mean? You know, many of you may have seen The Atlantic yesterday, had an article that says, when is this going to be over, and talked about a number of different scenarios. New York Times, the Seattle Times, the Puget Sound Business Journal, all the different places we get information have been hypothesizing about what's next. When do we get through this? When does this pandemic end? And what are some of the things that could influence that as we go forward? As you know, the science of COVID has been absolutely extraordinary. Since we first heard about Trevor Bedford and the work that he was doing and how he transitioned from the Seattle flu study to his work on COVID just about a year and a month ago, we have seen an explosion of understanding of a virus and of a health problem unlike really anything we've ever seen before in the world in terms of the rapidity with which we have developed things, the rapidity with which we have a vaccine, which is now, I saw yesterday in the Washington Post, about 35% of Americans have received at least one dose, and I believe it's about 9% have received two. And those numbers obviously change every day. Hopefully, they'll change as quickly as possible to catch up. So today, I am joined by four of our colleagues who are going to put in perspective some of the key questions about COVID, okay? What do the variants mean? What's the role of double masking? When can we travel comfortably as we move forward? Dr. Michele Andrasik is going to join us, Dr. Trevor Bedford, Dr. Larry Corey, and Dr. Josh Schiffer. This is a great panel, folks. I like to think of it as a dream team of COVID-19 researchers. In fact, we had to adjust the schedule because Dr. Larry Corey had a meeting with Dr. Fauci that just ended about 2 minutes ago, so he's going to be a little bit late. You know, it's amazing. When Dr. Fauci calls, Dr. Corey has to be on the call. But we are delighted that we're going to have Larry with us. So I'd like to begin by introducing Dr. Trevor Bedford. If you've been following the news, most importantly, if you've been following his Twitter feed, you have read about the work that Trevor's been doing. Trevor is a computational biologist who's in the Vaccine and Infectious Disease Division here at the Fred Hutch. He co-developed NextStrain, which is an open source tool to track how viruses change and how they spread through populations. NextStrain's been incredibly important for us in understanding how the novel coronavirus is evolving. Trevor is also an expert in tracking variants and predicting what comes next, particularly about how mutations can affect the spread of the disease. What I think one of the other key things is his Twitter feed, which Guppy will make sure that we all have access to, is considered one of the best sources of information about the pandemic from a viral epidemiology standpoint. So, Trevor, welcome. It's always terrific to have you here. Your enthusiasm and knowledge and ability to explain to people in a very meaningful way is absolutely critical. So, tell me about the variants. So, yesterday, the Atlantic article basically said we're going to have a great summer, uncertain fall, And what happens after that depends upon the variants. Now, they said the whole thing could be thrown off by the variants even now. So we might not even have the great summer if the variants emerge differently. What does this all mean? How should we be thinking about the emergence of these variants?
Thanks, Tom. So COVID or SARS-CoV-2, like any RNA virus, is mutating very rapidly. So if you look at seasonal influenza or seasonal coronaviruses or common cold viruses, they're all mutating perhaps once every month, once every couple weeks across the viral genome. So these mutations are really common. But what's different across some of these viruses is the ability for the virus to mutate in a way that it escapes immunity. And this is kind of why if you have measles virus, for example, you have the same vaccine from 1950, it still works today. There's no need to update the measles vaccine, whereas the seasonal flu vaccine needs to get updated every year because the virus is constantly evolving. For most of 2020, it wasn't clear where SARS-CoV-2 would fall between measles and flu. At this point, it's looking more flu-like than measles-like, where there's likely going to be some evolution. And so what things are looking like today is there are some variants that have emerged that have done different things. So the two kind of sides that we need to be paying attention to, there's B.1.1.7, which emerged from the UK, that is definitely more transmissible than kind of the original form of the virus. That is still at low frequency in the US. Some states maybe 2-5%, some states maybe 10% frequency. It's going to increase in the spring. It could result in more of a wave in, say, April, May than we would have expected otherwise. But I still do suspect that things will be brought under control in the summer, and there'll be very little COVID circulating with a combination of all of these infections that have occurred, all of this vaccination that's occurring. What I'm concerned about is that we could have something of a fall wave with these antigenically drifted variants that are starting to emerge, like B.1.351 emerging from South Africa. It's unclear exactly how much that will matter. There's a lot of work being done to try to make the possibility of booster doses of vaccine available if that should occur. So it's something that scientists are working on very quickly, very rapidly, but it's not something that I would be terribly concerned about as a everyday person.
And Trevor, the one question I've been asked is, well, gosh, the virus has been global since last January or so. Why didn't we see the emergence of variants in May or in June, or did we and we just didn't recognize it?
Yeah, this is a really good question, and it's actually something of a mystery. So if you look in the spring wave, there was a mutation or two, really just one particular mutation that happened back in January 2020 that spread and kind of was indicative of selection and evolution. But then there was this pretty big gap from January to September-ish when we weren't seeing a lot of action for the virus. And so it's not exactly clear what's going on here. The suspicion is that in the spring wave, the virus was kind of in a fully naive population where no one had seen COVID before. Whereas by the time you get to the fall-winter wave, there's enough of the population in the US and in the world that had seen COVID in the spring, mounted an immune response, and that creates kind of a different evolutionary circumstance for the virus to have different pressures to evolve in the fall than in the spring.
So as we come closer to immunity, a combination of people being exposed to the virus and many people being vaccinated, does that put additional evolutionary pressure on the virus to evolve to a form that might be more challenging to humanity?
Yeah, I think that if you imagine trying, let's say we didn't vaccinate and we just had this let's get to herd immunity strategy, the virus will have lots of pressure to evolve to escape that immunity. We've seen things like, again, this B.1.351 from South Africa that looks like from studies, you can see that perhaps we're getting almost as much infection of people that had previously recovered from wild type with B.1.351 mRNA vaccines give better immunity than this, so it's probably more protective there, but there's certainly an issue. However, with vaccination, we can bring down the overall number of infections as well. So even though you're creating evolutionary pressure for the virus, it makes it so that there is kind of fewer opportunities for the virus to evolve, and it's overall kind of the right strategy to be doing. But we do want a lot of vaccines and strong, robust immunity from those vaccines in order to achieve this.
Great. Trevor, thank you. And we'll be right back with some additional questions in just a second. I'd like now to bring on Dr. Larry Corey. Most of you know Larry. Larry was the president and director of the Fred Hutch. He is a professor in the vaccine and infectious disease division of the Fred Hutch, also in the clinical research and the public health division. He's a principal investigator for the COVID-19 Prevention Network. And it's always important to remember that Larry contributed much of his career to the battle against HIV and played a huge role in the development of effective treatments and potential vaccine development for HIV. Larry notably designed and co-led many of the Operation Warp Speed trials that have made such an enormous difference to patients around the world. So Larry, it's great to have you. And I did mention before you came on that you were on the phone with Dr. Fauci. And so that got you a little bit of a break in terms of time and things. So that's good. So Larry, where do we stand today? What's the thing that, if someone came to Larry Corey, what's the most important thing in COVID that's happening on the 23rd of February? What is it?
Well, a couple things. Number one is I think that the great thing is that remember that the vaccines appear to induce better immunity than natural infection. And this is a major achievement because I think we are seeing, especially I think what will be the press will cover this weekend, the J&J vaccine, which is global and shows efficacy against the South African variant, especially on severe disease, has pretty good efficacy in the United States, especially with severe disease. It's one dose and should add another 50 million doses to the ability to get vaccinated by the end of April. So I think that just thinking about Trevor's with respect to the variants, and it's been such a pleasure to work with Trevor and him educating me and getting him to be involved in the sort of public-private partnership groups that we've set up under Francis Collins and the Active Group to get his expertise into the companies as we start this issue of do we need a variant vaccine or not, and what are the decisions that we need to make to decide whether we do that or not. That's something that we still have some weeks to make those decisions, but we're certainly working towards those decisions. But to look at, certainly as we talk about the European variants and the UK variants, everything that we have, our current vaccines, the RNA vaccines are giving really high enough titers against antibodies so that the California variant or the UK variant, the B117 variant, we feel very confident that the current sort of strains in the that we have in the vaccine will work very effectively, and essentially we think as effectively as our current strain. So for our country at this point in time, it's really about vaccine coverage. Let us get everybody vaccinated as quickly as we possibly can, and I think we will have very, very good coverage with respect to protection against the disease with the strains we have now, the California strains. And I think very likely is what Trevor has predicted, the UK variant strains, the B117 strains that will occur in the next few months.
And so, Larry, one question, bringing sort of Trevor's work into this is, I read yesterday in one of the science trade publications that the FDA may consider accelerating the development of newer vaccines in the future against variants, that they may not need the same Operation Warp Speed size trials. For example, if Moderna or Pfizer were to re-engineer their vaccine against the South African variant or the Manaus variant or whatever comes up that looks worrisome, where does that stand? And do you see that as a viable way to think that we might be able to jumpstart the development of the next generation of vaccines?
Yes. I mean, I'm actually almost sort of talking about that there is sort of all of a push to sort of immediately switch to the variants and start these new strains. I have to say that at this point in time, I think it's important for us to step back and sort of look at, do we need to, does either boosting with our current strain, or do we need it all to have a strain variation a la influenza? And I think that's the first question that we need to answer. And there's an enormous amount of work being done now. And one of the issues is can we muster a study to take the RNA vaccine sort of into South Africa or into Sub-Saharan Africa or into Brazil to actually see how well it does? Maybe it will do better than we think. There is a cost, and there is a cost to us as a country, cost to us to re-immunizing. We need to get people immunized in the first place. And what's the best scientific goal to handle this? And I don't think we've answered that at the moment. There's sort of this, worry about it, and the press is there, but we need to muster the scientific evidence. If the scientific evidence supports that, then okay, we have the precedent of doing like flu. Do we really need to follow that precedent or not? And I think that's the major question. You asked me, what am I spending my time on? That and getting our elementary kids vaccinated are the two areas that I'm spending time on.
Getting the teachers vaccinated or the kids vaccinated?
Both. I think the teachers, it's the issue of getting them in the line to be prioritized to have them vaccinated. The kids, I think there is a desire more in our country than in Europe, and part of the issue has been to get the companies to unlink their development between the U.S. and Europe to allow us to go faster. I think we rank that as a higher priority than a lot of European and the European authorities, and that's one of the issues that has been slowing this down. So we've been working on unlinking that.
But Larry, do you think it's likely that the 650 people who are on this call will be getting a yearly COVID vaccine the way we get a yearly flu vaccine, or do you think that may not be necessary?
I'm hoping that it will not be totally necessary. Maybe we'll be able to do a boost. Some of it will be how long vaccine-induced immunity works and how much we put into memory, both our T cell memory and our B cell memory, the kinds of cells, so that if you get reinfected, you will not need to worry about going to the hospital on the ventilator, and we'll have a small cold. That's how I would approach it. At the moment, I'm thinking of it that way. That doesn't mean it will be that way, but so I think we don't quite know.
Okay. All right. Great. Larry, thank you so much. We'll be back in just a second. I'd like to bring on Michele Andrasik at this point. Michele is a psychologist and director of community engagement for the CoVPN. She has a similar role with the HIV Vaccine Trials Network. And for those of you who've been following the Hutch, you can see that this pattern of so many of the people who are so essential in our HIV effort, like Michele and Larry, were able to rapidly take that expertise in viruses and be able to bring it to COVID. And it made such a big difference in how we did this. She's a senior staff scientist in the Vaccine and Infectious Disease Division, a clinical assistant professor of global health at the University of Washington. And Michele's area is looking at equity in COVID-19 vaccine trials by making sure they include people from communities that have been hit hardest by the virus. And she's been working on boosting confidence in vaccines and uptake in these communities. So Michele, you and I have done a bunch of these together, and I always find your insights incredibly helpful. But I've got to start off by saying I'm a huge sports fan. Okay, so it's not a random thing that we ended up doing the Super Bowl opportunity, which we'll talk about in a second. But yesterday, I read a really disturbing article. I said, big fan of the NFL, big fan of the NBA. And they actually interviewed players from the NFL and the NBA. And they found that about 45% of players from the NFL and the NBA were highly skeptical about the vaccine and are leaning toward not getting it. Now, these are leagues, those two leagues particularly have a large percentage of black players. You have studied this issue extensively. Are you surprised? how high is the mountain we have to climb to be able to vaccinate people, not just develop the vaccine, but get people to actually take it?
Well, no, I'm not surprised. I saw that article as well, and I think there still exists a great deal of skepticism. We've been working incredibly hard to address that skepticism. At the foundation of everything we do is really relationship building. So we really capitalize on the relationships that we have had for decades through our HIV work, really working with some of our longstanding partners to address some of the skepticism that we see in not only Black communities, but Indigenous and people of color communities. So partnering with trusted voices, working with our partners at the National Medical Association and the National Hispanic Medical Association to not only educate the larger community and increase awareness for the larger community, but also address some of the skepticism that is held by BIPOC providers. So really ensuring that we have the information. One of the interesting things about COVID that sort of parallels HIV is the politicization of COVID and prevention measures. So we're really trying to get out ahead of that and ensure that communities have the resources and the materials that they need to make informed decisions, and to engage in conversations around what the fears are, what the uncertainty is, and acknowledge that skepticism in medical and research institutions is probably very healthy and a defense mechanism to ensure the safety of yourself, your family, and your communities. So really, acknowledging that history and working to build trust and relationships. So we've really worked to strengthen our reputation as a trustworthy organization. And one of the ways that we have been doing that, and one of the things that I'm incredibly proud of the Hutch, is that we've partnered with some of our longstanding community leaders to have a vaccination site we have one and we're working on others. This Saturday at New Beginnings Christian Fellowship, in partnership with African Americans Reach and Teach Health Ministries and their network of Black churches, we were able to vaccinate 312 individuals, mostly older adults, elders in the Black community. And there were a great deal of fears and uncertainty that people came to the vaccination site with, and they had ushers there who were going through the vaccination sheet with individuals, answering their questions. And it's incredibly powerful to see people who look like you, who are part of your community, involved in that effort and really there to discuss your fears and concerns. It makes a huge, huge difference. And my inbox has been inundated with community members reaching out to express how they feel about the success of that program. And as you know, Tom, as you stated before, we sort of jumped on the opportunity to create the 30-second public service announcement that we aired during the Super Bowl. And that's really a good example of how we're talking about vaccines, and how we're sort of framing the issue, understanding that people have reservations and have concerns, and really urging them to get the information, make sure they have information from trusted sources and through credible voices. And we have the video here if you'd like us to share it today.
It really is. It really is terrific. Do you have? Can we pop it up now?
I think it's in the queue.
Oh, perfect.
When we got safe and effective vaccines, you stayed on the sidelines. We get that. And when leaders got vaccinated, you decided to sit this out. We understand. When a vaccine is desperately needed to restore some normalcy, you may still be doubtful. That's okay. We can work together to get answers to your questions. This pandemic took enough from Washingtonians already. Don't let it take our future. Let's get back to living. PreventCovidWA.org.
That's a great vaccine. It's a great commercial about vaccines. It makes me really happy and proud the work the Hutch was able to do in that area. It's just absolutely extraordinary. One last question for you, Michele, and this is true for all of us because we're all dealing with this. But you're a psychologist, so you're going to know the answer, which is we have loved ones, we have brothers, we have sisters, we have in-laws who are skeptical, okay, in our families, despite us being doctors and researchers and scientists. And, I bet of the 640 people in this call, they all have loved ones in the same situation who are skeptical. How is it best to engage, to talk to your sister-in-law who says, I'm just not sure about the safety? How can we be helpful within our own families to promote vaccination?
Well, we have created several resources for you to do just that. We have infographics, we have videos, we have slide sets with all of the information. I mean, one of the, I have many members of my family and my personal and professional life who are skeptical and have fears and uncertainties. So engaging in open and honest conversations about the work that we do, pointing them to resources with accurate and up-to-date information, and also asking, where are you getting your information from? I always ask, my cousins, where did you get that information, and how do you know that that's a trusted source? So we created a website, PreventCovidWA.org, that has all of our infographics, videos, materials of all kinds that can help you have that discussion with your loved ones, and you can point them there. It is a credible source of information. And I think, in these conversations, it's also important to give them some insight into science. There are things that we know and there are things that we don't know. So, and I think we have to be very transparent and honest about what we know, what we don't know, and what we're working to find out. And I think that really sets a nice open conversation about, what we currently know, and then for our communities to weigh the pros and cons. One of the things that I discuss also is how COVID is impacting my community in terms of hospitalizations and deaths, and then what we know to be true about the vaccine and the impact that could have on hospitalizations and deaths in our community. So being able to weigh those pros and cons, I think, is also an important point.
So Michele, thank you. We'll be back in just a second. I want to bring on our fourth and final guest, Josh Schiffer. Josh, come on. Josh is an infectious disease physician. He's a researcher as well in the vaccine and infectious disease and clinical research divisions. He's a mathematical modeler who works to look at the patterns of spread and to understand spread. He was among the very first to recognize the significance of super spreader events early in the pandemic. And some people describe Josh as a mask evangelist, which is fantastic. And we're delighted to have Josh with us here today. So Josh, I'm going to ask you the same kind of question that I asked Trevor, who's also a modeler. What do you think the future holds in terms of the pandemic? Do you think that we can avoid a fourth wave? Do you think a fourth wave is inevitable? What do you think about the next 6 to 8 months?
Thanks, Tom. Well, our group has been modeling the King County epidemic very closely, and so we focused there, but I think a lot of the conclusions we're drawing can be generalized to locations across the country. And, prior to the new variants, the results were really looking very promising that a fourth wave could be, severely mitigated or eliminated altogether. I think with the newly infectious variants, it's probably going to be difficult to prevent a fourth wave altogether. And I think we're already seeing some evidence of this in Florida, where the total number of cases are going down, but the number of cases, the absolute number of cases with a new variant appears to be slowly trickling up. But that doesn't mean we need to live in fear or dread. I think that the thing about the fourth wave is it could take on really any numbers of shapes. I think there is a worst case scenario in which the fourth wave, in which we don't vaccinate quickly enough, and it could look a lot like the wave we just endured, with one important hopeful exception, which is that even if the cases are equivalent, it's very likely that the proportion of people who require hospitalization and death will be much lower because we've done a nice job in terms of vaccinating society's most vulnerable. And so, on the other hand, and I'm increasingly, as I hear people like Larry talk about the J&J vaccine, and as it seems more and more likely that we're going to be able to exceed the Biden administration's initial vaccine rate goals, I think we could be dealing with a curve that is flattened, where the number of circulating cases is very low. The one thing about flattening a wave is that it prolongs it, and so we could see a slow, wave involving a relatively low number of people that extends throughout the summer and fall. There's some precedent for this. If you look in Europe, some countries like Ireland and the UK had very steep, sharp waves with the new variant, whereas Denmark had a considerably more flat wave. And so we'll need to see. And so really what we've been focused on in our group is how do you mitigate this? And really the key point is rather obvious, which is just how many shots per day can you give across the population? And what's also important is whether there will be any loss of efficacy against the new variant. So as Trevor and Larry mentioned, I think the fact that the B117 variant appears to be very well covered by our current palette of vaccines is great news. But it's very important that we establish a very wide net of vaccination to account for the South African strain. And then the final thing I'll say is that in this 2 to 3 month stretch where we're still rolling out the vaccine, the strategies that we've known and understood for some time are of critical importance. But I think that we actually know how to use them better. So in regards to masking, I'm a big adherent for wearing the best possible mask possible if you are entering a possible super spreader event. So if you are an essential worker in a prison or in a crowded factory or in a supermarket, then I would advocate for wearing a K95. It's simply a better mask. It prevents more viruses from getting through. And I take the same approach when I go to the supermarket. But when I'm walking the dog in the park, I just wear a cloth mask because I think the risk of transmission is very, very low. And so I think we can take some of the approaches we've used and just be a bit more nuanced with them. As far as when the pandemic will end, what I would suspect is that it will peter out. And one of the key epidemiologic features about the pandemic has been geographic heterogeneity. So it would not surprise me at all if many states do extremely well over the summer, but there are sporadic outbreaks within specific communities, within specific states, as we are seeing this out. And this really gets to how important Michele's message is about reaching communities that are reluctant to get the vaccine so we can try to prevent these small fires from occurring across the country.
And so, Josh, one other, I hate to keep bringing back sports, but there's a very interesting study from the NFL on what, as the NFL looked at their experience with all 32 teams and 70 players per team and 25 coaches, so 150 personnel per team, and they monitored and tested extremely intensively, and they came up with a couple of observations. I'm curious how these resonate with you. The first is there was not a single example of COVID that spread during an actual football game. Okay, so when those guys are, and they're screaming at each other across the line, and they're not being social, they're not socially distancing, they're tackling, and they're, coughing and things like that. And there was not a single case of spread in that environment. There was not a single case of spread on an airplane. Of all the planes that they took to go to all the different games and all the other things, not a single case in the airplane. It was cars, it was eating, it was buses, it was things like that became became more important in terms of and they did pretty well because they tested so intensively. and then they obviously promoted masks. Tell me a little bit about what you think of that data, and can we begin to refine? And I think you talked about a little bit that you wear a different mask at Safeway than you do at the park.
Yeah, I agree. This resonates on a personal note as well. My two sons play competitive soccer, and one of the things I've done on the side is really work with Washington Youth Soccer to say I think it's okay for the kids to be back on the field, and it's been such a pleasure to see that done in a way that I think is safe. So, the one caveat that we need to be careful with is that the epidemiology of this virus is very weird. The super spreader phenomena is very well understood, that one person can walk into a choir practice, interact with a limited number of other people for an hour and infect almost all of them. But the flip side of that is that most people who get the virus don't infect anybody. And so in some cases, the absence of evidence is not quite enough. The absence of infections is not quite enough to rule out the possibility that it can occur. I mean, for example, we know super spreader events can occur on an airplane, but it just speaks to the fact that at the end of the day, if everybody is doing the little things correctly, which I think the NFL teams by and large were when they were traveling, it really does decrease the risk substantially. So it gets back to the same points of masking effectively, and if you need to be in a crowded environment, doing everything you can to maintain a physical distance.
Okay, so Josh, one last thing before we get to the group discussion. So I wear a KN95 because I can't get an N95, but then I put this special Fred Hutch mask on top of it, so it's branded as Fred Hutch as well. Tell me about double masking. Is this crazy?
Yeah, I mean it's a little bit controversial. I've seen colleagues of mine say it's not necessary, but to me, the first principle is wear the mask properly. So if you wear two masks incorrectly, then it's probably not doing much. But the mask, there was a nice study from the CDC using sort of crash test dummies, looking at the number of particles that get through two masks, and it's clearly more effective. And so I would say for people who don't own K95s and are going to a restaurant to pick up their food, not to eat there, and also to get, to go to the grocery store, where contacts are inevitable, that two masks makes a lot of sense to me.
Okay.
And I advocate for that.
Let's bring everybody back for our discussion and questions. I want to say we have 59 questions. We are not going to get through 59 questions. I am absolutely certain about that. The first one I'm going to throw to Trevor, which is actually the last question asked, which is, Trevor, you made your career in flu for much of it, and someone asked, what's going on with flu this year? And have you totally given up on flu?
Yeah, so what we've seen globally is there's almost no flu circulating. There is basically no flu season in 2021. You can think of this as that this number that people may be familiar with. So there's this concept of R naught or R effective, which is the number, and Josh touched on this. It's the number of secondary infections that one infection causes. And for flu, during a flu season, that's usually maybe 1.5 or so, and that gives you an epidemic. The mitigation measures that we put into place in the U.S. and elsewhere in the world has basically dropped that below 1, so that there's no flu epidemic. And you can make sense of this in that the COVID R naught number is more like our effective number. Sorry, R naught, if we're not doing anything number is more like 3 rather than 1.5. So the same measures that will completely suppress flu in a population will still result in a COVID epidemic, and that's effectively what we're seeing. There's been small outbreaks of influenza in Cambodia and Bangladesh and a few places in the world that are being used to kind of help inform the vaccine strain selection that's going on right now. But it's going to be very challenging to pick the strain this year, just because there's so little circulating.
A little bit. And Trevor, I think one of the things to emphasize for our audience, you're not giving up on influenza, are you? I mean, you're still going to be involved in influenza epidemiology.
Yeah, definitely. And I think that's basically the same processes that we're And the same sorts of models that we're running for flu and have been developing for flu will be working for COVID, and that kind of tracking this evolution will be extended across both flu and COVID going forward.
Okay. And Michele, this question's been asked a couple of different ways, which is what are the risks getting the vaccine? And if somebody is asking that, I think it's really important that we get a clear answer from you, Michele, on what the risks are of getting the vaccine.
Well, that is an excellent question. We are creating an infographic for that right now that will soon be up on our website. And I think, there are, side effects that will have. Generally, they are experienced as moderate or mild. They generally last for, less than 48 hours. We have seen very rare cases. The last MMWR report from the CDC indicated very rare cases of anaphylaxis, 90% of which happened in the first 30 minutes after injection. And I know here in Washington State, all of our injection sites have a very conservative anaphylactic protocol where if you have any history of allergies, you will be monitored for 30 minutes and then 15 minutes just generally. So, and I know that a lot of people are very, very concerned about an allergic reaction. So we have that information also available looking at those reports. But I think, again, this goes back to weighing the pros and the cons. We know that we have a safe and effective vaccine that prevents severe disease, hospitalization, and death. And, I think, that certainly the pros in terms of how COVID impacts communities and the disparate impact of those communities outweigh the cons. So, we have all of that on the website. If you want to get into the specifics about, the percentage of time that we see the side effects, what you can expect. But generally what we see are just short-lived, less, 48 hours or less, they're gone. You can treat them with over-the-counter medication. And I think one of the things that we want to point out as well, that people have asked whether or not they should medicate before getting a vaccine. So whether they should take over-the-counter Tylenol or aspirin. And it is recommended that you do not do that prior to vaccination. And if you do, feel fever or soreness after the vaccination, you can take over-the-counter medication, and that will alleviate the mild to moderate side effects generally that you are experiencing. I don't know, Larry, did you want to add anything else?
I think you answered that question perfectly.
Great. So Josh, this one's for you. And it comes from someone who says, speaking of choir practice, her choir has gone dormant since March of 2020 and anticipates being able to perform again at Christmas. And she said, I know that group indoor singing is one of the riskiest things you can do COVID-wise. Is our timeline for returning to concerts crazy?
No, I don't think it's crazy at all. I would just anticipate the need for flexibility. I think that the way that the state has dealt with this, it's obviously very difficult, but phasing in the degree of allowed activities is entirely the appropriate way to go about opening society. And for choir practice to be safe, essentially we need to be in a situation where we are like Australia, where there are no circulating cases, or if there are circulating cases, we are aware of them. And so, I'm guardedly optimistic that that's very much within the realm of the possible by Christmas, but obviously there's a lot of unknowns, particularly in regards to the new variants. But if I had to wager, I would say yes, it will be possible, but just be flexible.
Okay. This is a perfect Larry Corey question. Larry, you can address the end of Josh's question, but this one's such a good Larry Corey question, which is, in less than a year, a multinational effort has created an effective vaccine against a previously unknown virus. HIV has been here for 40 years. If we launch a similar effort, could we create an effective HIV vaccine in the next year as well?
I'm not sure we could in the next year. The variation and the immune defense mechanisms of HIV are really considerable. It is the HIV scientific infrastructure that allowed us to do this in COVID. This would not be done without HIV. First of all, the VRC that did all this work on proline stabilizing the prefusion protein, which is where all the effective vaccine so far has been. The one that doesn't look very good, the AZ study, is not this prefusion, or the AZ vaccine is not this prefusion complex. That was started because of HIV. Our ability, our statisticians, our labs, our ability to do these clinical trials in record time and design them with the kind of of staying power and size that the data have allowed us to get are because of the HIV infrastructure. But HIV mutates what SARS-CoV-2 has done in 10 months, is less than 2 days for HIV. And so we'll let Trevor comment a little bit on that. And there are some immune defense mechanisms for T cells that HIV has, as well as where its basic infrastructure is, as far as where it lives, where it reactivates, its latency characteristics. So it is just a harder target. Now, having said that, when you really get the public-private partnerships, and what has left HIV is essentially the pharmaceutical industry, their ability to manufacture, their ability to iterate, that has left the HIV field over 15 years ago. And when we have them back at the table, and they actually listen to academia, and they work together, we have done amazing things. So there is something that momentum and sort of de-risking from a financial point of view and a commitment point of view does allow science to be looked at. And I think all of us have to take a look at the cancer field and our major health problem fields and look and say, we created a structure here that allowed us to solve a problem that was really amazing. And when we all want to do it, and you have momentum and you have everybody pulling the oar together, we can really solve biological problems. And I think it's a model that we need to take a look at with respect to, our major health needs.
So
full stop on that.
Okay, and Trevor, did you want to add something?
Maybe just very small, that if you look at something like influenza, it's mutating quite rapidly, but basically you see this strain replacement where kind of the new version replaces the old version, so you can use kind of one vaccine to still have things work pretty well. Whereas HIV, you get this enormous diversification where all these different lineages are kind of going in different directions in terms of their immune response, antigenic response. And this makes it very challenging to just have a vaccine that works across things.
Okay. Michele, next question for you is about the rollout of the vaccine to the general population. People who aren't elderly, people who don't have comorbid diseases, don't have other diseases at the same time. What are your thoughts on when, a 35-year-old man or woman can walk into CVS and get the vaccine there? How far are we from that, do you think, Michele?
Well, it really depends on vaccine availability. I think that here in Washington State, the governor and the mayor have really clear phases of the rollout. So once, phase 1A and 1B are complete, we go on to the next phases. They also have a really great tool that allows you to sort of sign up to figure out which phase you are in and to then be contacted when it is your turn. And again, all of this will really rely on vaccine availability, which we're hoping will, ramp up very soon, and we'll have constant flow of vaccine. Currently, we are not at that stage. And in the state, we are now in phase 1B. So, it's going to be quite some time for that person to be eligible. But when that will be, again, will depend on vaccine eligibility. And if you want to go, Washington State Department of Health has a great COVID resource, as does Seattle King County Public Health. You could go to either of their websites and do a COVID search and see all of the information on the phases and the rollout, and also get yourself in the queue to be contacted when your time is near.
And Michele, one of the things I've told this to Larry a bunch of times, one of the things I'm really worried about is right now we're in a time of vaccine shortage, a relative shortage of vaccines. We're still rolling it out, and the demand is high because everybody who believes in vaccines, reads the science, wants to get them. What I worry about is that we're going to very rapidly switch from a time of supply shortage to a time of demand shortage. That what I worry about is that once we vaccinate all the people on this call who want to be vaccinated, which will happen pretty soon, not that far from now, that the 40-year-old mom or dad, who lives in suburban Seattle, okay, is that person going to have the same urgency to get the vaccine? And yet, what I'm hearing from Trevor and Josh is that timing of vaccinating that 40-year-old in Kent or that 40-year-old in Tukwila or that 40-year-old in Tacoma is just as important as the 85-year-old in the nursing home if we're going to try to achieve those kinds of goals. And so the work you're doing in terms of approaching vaccine hesitancy is so incredibly important, in my mind, at least.
Yeah, and for those of you who are interested, we have several really straightforward infographics on our website that really speak to that issue. Why should I, as whatever your age is, healthy, no pre-existing condition person, get vaccinated? And if you need, information and talking points to talk to your family, your loved ones, or even, to inform yourself, I really encourage you to check those materials out because we have provided information about that.
So, Josh, this next question. Oh, go ahead, Larry.
Well, I guess I wanted to go back to this issue of hesitancy as risk-benefit and to the choir practice. Frankly, I don't think you have choir practice unless everybody is vaccinated. And you shouldn't be in the choir in practice if you're not vaccinated. The other only option would be that you do what the NFL and NBA do, is that if you're going to be there the day before, you need to be negative, or the day of, you have to be tested by an assay and know you're negative, you're going to walk in the room. And I think those are the risk benefits here are social interaction risk benefits and community-based benefits of knowing that there's some element of protection here. And I think that's those kinds of social, we're not talking about forcing anybody, but you can provide pressure with respect to your obligation as a person. We know this virus can escape from prior, it's an escape-resistant neutralization. So we know we actually need, it's really vaccine coverage and vaccine immunity that's required to do something on a population basis. It's not herd immunity, it's vaccine coverage, it's vaccine-induced immunity. And that's the sort of lingo we have to change.
Right. That's a great point. Josh, the last question is going to go to you. It is the Fred Hutch Cancer Research Center. So cancer is a big part of what we do. And Josh, I imagine many of the consults and patients you took care of were cancer patients with infectious problems before this in your career. Many questions have come in on the interplay, and many of them are individual, and Guppy and others will hopefully try to get some answers to the very specific questions that were asked. What do we know about the interplay between cancer patients undergoing treatment and vaccination? How should our patient population be thinking about this? I can tell you that the administration of the Fred Hutch is advocating almost daily. Like today, I have a meeting with the Washington State Department of Health to advocate for cancer patients, and with Dr. Shah, who's the new Secretary of Health for the state of Washington. advocating for cancer patients. Tell me about what you think about cancer patients and COVID, vaccination in the cancer setting.
Yeah, in my opinion, the majority of cancer patients who we see should be offered the vaccine as quickly as possible. There's some context-dependent exceptions to that, where for example, prior to a transplant, we usually don't vaccinate because the immune system is in effect reborn, and so we wait until after the transplant to provide vaccines. But in that context, for other pathogens, we're very careful, for example, about making sure family members are vaccinated to prevent, spread within a household. And so, yeah, I think that this is a critically important target population for vaccination, who carry risk factors of developing severe COVID, which is really the number one target that we wish to prevent with the vaccine program. So I'm in agreement with that Hutch policy.
So, Josh, I want to thank you, and I want to thank the panel. I basically lost track of time. The questions were so good. The answers were better. Were great, too. And so thank you. And I want to just say one thing to our donor community, which is since the pandemic started, we received more than $9 million in philanthropic funds to fuel COVID research. We have spent all of that money and more. And I thank you. Without you, Michele wouldn't be doing what she's doing. Josh wouldn't be doing what he's doing, nor would Trevor or Larry. So our donor community is incredibly important doing this. What I can tell you is the job is not finished. We still have so much we're doing here at the Hutch. And so your contributions make an enormous difference. I know I've spoken to many of you personally about your contributions to COVID. It makes a huge difference to what we do. And thank you for thinking about us. Our next Monthly Science Says will be a month from today on March 23rd at noon Pacific time. And we'll be talking about big data and how big data is accelerating and transforming cancer research. So save the date, encourage colleagues, friends, families, other members to attend. You can also learn more about fearless science that our researchers are doing at fredhutch.org/annual report. And we also have a site that talks about the COVID vaccine at preventcovidwashingtonwa.org. So that's great. So a couple of things to end with. It's been a tough year, absolutely tough year, but we know there is light at the end of the tunnel. And we know that our ability to get vaccinated, to wear our masks, to get us through the next 6 to 9 to 10 months, we're going to get there. And I think we're going to find that the time, as you heard today from our panelists, will be better between now and the time we finally get through this. And we continue to work extremely hard at the Fred Hutch on how COVID can be curtailed, how we can make things better for our cancer patients. And don't anyone think we're not doing cancer research 24/7, because cancer is still an enormous problem for our society, and we are working unbelievably hard. Cures start here is something we all believe in deeply here at the Fred Hutch. Thank you all, and have a fantastic day.